there's a mix of predominantly maybe patients and perhaps a few clinician colleagues joining this call. And what I'm going to do is I'm going to really be kind of speaking mainly to kind of the patient kind of audience. So talking about this project and talking about something which is really important to a lot of the patients, and that's their the risk of getting cancer after transplantation. And as he said, probably speak for about maybe 45 minutes or so, and then leave some time for some questions. And while I'm going to focus a lot on the project itself, I really want to have a bit more perhaps of an open discussion and answer any queries that people have about the use of patient data. Because I think that's something which I'm very passionate about, that we do try to make the best use of all the data that we collect for our patients. Some of that data is collected because we have a legal obligation to do so. So, for example, we collect data that we can let NHS Blood and Transplant, who's the regulator, know how our, what our outcomes are like. But other data, obviously, we collect for various other purposes. And hopefully, what I'll show you over the next few slides and some of the early kind of findings that we have from this particular study, which is how valuable data can be for research purposes. So this slide here is taken from the UK Renal Registry. So this collects data for people who have very advanced kidney disease or have kidney failure. So there's lots of dialysis data and there's lots of transplantation data. And what you can see on the slide on the left is that cancer, which is, or malignancy as is written there, which is the sky blue line, you can see that for many years it was always rivaling cardiovascular disease as being one of the leading causes of death for people who have kidney failure, whether they're being treated with dialysis or whether they have a transplant. You can see the little blip in 2020, which is the black line for infection, as I'm sure you will all remember. That was obviously the impact of COVID, which is settling down now, and malignancies or cancers remains one of the leading causes of death for people with kidney failure. And if you look at the figure on the right, you can see the difference in cancer risk for kidney failure people if they are on dialysis versus if they have a transplant. So there's a more than doubling of risk. And cancer after transplantation is a risk factor for anyone, regardless of what kind of transplant you get. And this slide is a summary from the United States, which looked at the various cancers. And there's different ways that we can think about cancer. We can think about the incidence. So how many cancers are we going to see for people? But also then what's the risk of dying from that particular cancer? So you can see that, for example, the commonest cancer that we will see will be the skin cancers and something called Kaposi sarcoma, or the non-melanoma skin cancers. And many of the people on this call may have had some of those skin cancers, squamous cell carcinomas or basal cell carcinomas. They're very, very common, and that's why we give some protection advice to all of our patients, but they won't be the leading cause of death. And you can see the leading cause of cancer-related death are usually things like lymphomas and kidney cancers, etc., etc. And when we think about cancer after transplantation, there's really three different types of cancers. So there's the cancers that we think the actual act of transplantation has increased the risk for that particular cancer. And by that, I really mean it's the impact of the immune suppression and the anti-rejection tablets that you need to reduce the risk of rejection. But obviously, by weakening your immune system, we leave you more susceptible to things like infections and cancers. And there are certain cancers where the risk is increased because of that. Then there are some other cancers which are actually associated with the organ failure itself. So, for example, people with kidney failure are at a much higher risk of things like thyroid cancers and kidney cancers. And these are kidney cancers on their old kidneys, not their transplant kidney. And of course, liver transplant patients will have an increased risk of liver-related cancers, whether they had liver cancer as a cause of their liver transplantation or not. Then there are some cancers where there seems to be absolutely no link either with organ failure or immune suppression, and most studies would suggest that prostate and breast cancer are part of that. So in fact, we now will often list people for transplantation if they have mild to moderate kind of severity for their prostate cancer, for example, because our current thinking is that transplantation and the anti-rejection treatment that you need afterwards is probably not going to influence that risk very much. And cancer is obviously very, very common. Cancer Research UK often says that 1 in 2 of us will be exposed to cancer at some point in our life. And the reason for that is you can see that there are so many lifestyle factors or other risk factors for cancer. And this is for the general population. And the reason why transplant patients have a higher risk for cancer is because getting a transplant and getting the immune suppression afterwards will increase the risk for these things. So a lot of people with organ failure will have an element of chronic inflammation. Obviously, there's immune suppression, which I'll speak about a little bit further, but the immune suppression can cause a higher risk for infections, and some immune suppression, such as steroids, will increase the risk for obesity. So all of us have a background risk for cancer anyway. If we were to get a transplant, we increase the risk for certain cancers. And most of you will, certainly the patients will remember when you came in for your transplant and where you're getting your counseling, we will always talk about the increased risk for cancer associated with your transplant. And this is just showing the cancers which are a much higher risk after transplantation, because most of these cancers will have some kind of infection related component to it. The immune suppression that you get will reduce your susceptibility, so you're much higher risk of getting certain infections, and certain infections have a close relationship with certain cancers, and that's why these particular cancers are more commonly seen after transplantation versus the general population. And I'm sure for most of the patients who are on this webinar, you will be familiar with some of these medications which you will be taking for your transplant. There are so many different transplant centres in the UK, and all of us seem to do something ever so slightly differently when it comes to immune suppression after transplantation. But all of these different agents, whether we use them for induction, so something that we use at the time of your transplant, or whether it's your maintenance immune suppression, so what you are taking on a daily basis, have a certain relationship with cancer. And there's a lot of studies out there which study this in greater detail. What I will do is I will just summarize what we know. So steroid treatment doesn't seem to impact on the risk for cancer. And for people who get basiliximab, so that is a form of induction therapy. So for people, especially after kidney transplantation, when they come in for their transplant, they will get that at the time of their transplant as a one-off dose on the day of their transplant and then a few days later. They don't seem to have any relationship with the cancer. It's mainly these agents, and most of you will be familiar with some or all of these. So for start, with the green box, so these are what we call lymphocyte depleting agents, and they are commonly used after certain types of solid organ transplants, certainly for people who get a pancreas transplant, and for people who may be at high immunological risk. Depending on which center you've had your transplant at, you may have received this type of induction as routine. So from a kidney transplantation perspective, there's 23 adult kidney transplant centers in the UK. 4 of them use alemtuzumab as induction immune suppression, so that's what you're going to get at the time of your surgery. The other 19 use basiliximab that I've already mentioned. Belatacept is what we call a co-stimulation blocker. It's not very commonly used in the UK, but where we do use it, it has been shown to be associated with a higher risk for lymphomas, especially if you've never had any exposure to a certain type of virus, EBV, which is very commonly associated with it. So we can only use it for people when they've had previous childhood exposure to the EB virus. Most people on this call will either be on tacrolimus or cyclosporin. They are both associated with a higher risk of cancer, and it's a very dose-dependent risk. So the higher your exposure, the higher your drug levels, and over accumulation of time, the higher your risk for getting cancer. And again, the anti-proliferative agents that we use, mycophenolic acid and azathioprine, are both very commonly associated with cancer, perhaps azathioprine more so, and has a greater relationship when it comes to skin cancers. So immune suppression is certainly probably the big risk factor when it comes to cancer risk after transplantation. However, it may be that that's not the only factor, and it may be that perhaps we put too much emphasis on the immune suppression. And sorry, before I go on to that, I'll just talk about sirolimus, which some of you may be familiar with. That's actually been shown to reduce the risk for cancer, but we'll talk a little bit more about that later on. And that's commonly used for many patients, especially when we want to try and improve kidney function a little bit, or if there's a concern about side effects from the tacrolimus or cyclosporin. And as I mentioned, we commonly associate these immunosuppressive drugs with the risk for cancer, but we perhaps may be overplaying this. So these drugs are used by many other specialties as well. So for example, tacrolimus can be used by dermatologists, but ophthalmologists will often use many of these drugs. And some ophthalmology researchers, what they did was they looked at the risk for cancer for people with eye conditions where the only indication for using these drugs was inflammation within the eye. So they didn't have any what we call systemic inflammation. And what they found was that actually there's not really much of a signal for cancer with these immunosuppressive drugs, which is completely different from what we see in other forms of, say, organ failure patients. And the suggestion here is that there may be an element of risk associated with these drugs, but when it comes to people who get solid organ transplantation, the inflammation that they get in their body from either kidney failure, liver failure, heart failure, etc., probably has an additive effect. So it's not all about the immune suppression, but clearly immune suppression is important. And this is clearly an important issue because for a lot of patients, cancer is a big worry for them after transplantation. And this is a really nice study which was done in Australia. And what they did is they actually asked patients themselves, I think in this particular study, they were kidney transplant patients. And in this qualitative research, they actually asked patients, what do you worry about after transplantation? And just like many transplantations, you can see their biggest worry was actually their kidney transplant, the risk for rejection, and whether their kidney function was good or bad. But you can see that cancer ranks pretty high for patients as a worry. And certainly from our perspective as transplant doctors, we worry about cancer because the literature would suggest that outcomes for transplant patients when they get cancer are perhaps not as good as what we may see in the general population. And this is American data, and I'll come on to this, but we always have to be a little bit careful when it comes to translating American data across the pond. But this particular study suggested that outcomes after transplantation for people who get cancer are not particularly good. So 4 years from a cancer diagnosis, half of patients may either have died or may have lost their transplant. So other than perhaps lymphomas, where there's been some improvement over the last decade or two, for other patients, their outcomes may not be as good. I'm not sure if we see such outcomes in the UK, but this is what the US researchers have shown across the pond. And I guess we can speculate on why outcomes may not be as good. So screening, for example, is very, very important, and we're very strict about transplant candidates undergoing their kind of mandatory screening, whether that's breast screening, cervical cancer screening, smear tests, or colonoscopies for people who are eligible for those national screening programs. And transplant patients don't need any more frequent screening, but they do need to attend whatever screening they are invited to. And we always strongly recommend all of our patients attend whatever screening programs they are eligible for. One of the other reasons why maybe outcomes are not as good for transplant patients when they get cancer is because their care may be slightly more complicated, or maybe deemed to be more complicated, and perhaps transplant patients are not getting the same treatment opportunities as people in the general population will. So, for example, there's a new kind of breed of therapies called checkpoint inhibitors, which have been fantastic for people with certain types of cancers. For example, melanomas, which is a type of skin cancer, or kidney cancers, checkpoint inhibitors have been used very successfully. But for transplant patients, and it's not just kidney transplant patients, but other solid organ transplant patients, the use of these checkpoint inhibitors is associated with a much higher risk for rejection. So up to maybe 50% of transplant patients, if they use these checkpoint inhibitors, may get rejection. So perhaps the fear of rejection means that people are not getting the optimum therapy as the general population. The other reason why outcomes may not be very good is because we don't actually know what is the best thing to do with your immune suppression after a diagnosis of cancer. And depending on which clinician you ask, they will probably give a slightly different answer, whether we should taper down on some of your immune suppression, maybe we should stop one of your tablets, or whether we should just leave it alone. And a lot of that depends on what kind of cancer you have, but also reflects the fact that we don't have very good data on what is the best thing to do. And I mentioned earlier that tablets like sirolimus have been shown to reduce the risk of cancer, and that's for any type of cancer, but especially skin cancers. And there's been some studies for people where they get recurrent skin cancers, and when they convert from their tacrolimus or cyclosporin that most of you will be very familiar with, if they stop that and they convert over to sirolimus, they do get a reduced frequency of skin cancers. And this particular study that was published looked at all the studies, whether people start with sirolimus as their immune suppression, or whether they start with something else and they switch over to sirolimus. Certainly, without any doubt, sirolimus is associated with a reduced risk for cancer. So it sounds like a fantastic anti-rejection tablet. What's the catch? There's always a catch. And the catch with sirolimus is that it's associated with a few different side effects, but also a much higher risk for cardiovascular disease related deaths and infection related deaths. So most of these immunosuppressants need to be used very carefully, and they need to be personalized to each patient and their unique circumstances. And the other problem is that the literature that we currently have is pretty poor. A lot of the literature is very old, and a lot of the literature often doesn't reflect UK practice or the patients that we have in the UK. And if we look at the UK, these are the only two studies that we have. The top one you can see is 15 years old, and that looked at how much cancer we see after transplantation. And again, that was using UK transplant registry data. And the study at the bottom, which was published a few years later, which I was involved with, was looking at the risk of dying from cancer after kidney transplantation. And this is what it showed. So you can see that the commonest cancer that we actually see are skin cancers, and that's certainly what we would see in day-to-day practice, that skin cancers are without a doubt the commonest cancers, and that's why we're very aggressive with some protection advice to our patients, either when they're traveling abroad or certainly I know the weather's turned just now, but the last few months with kind of the great weather that we've had, we would always encourage very good skin protection. But you can see the chance of dying from skin cancer is actually very low, and I imagine most of those will probably be melanomas. The commonest cancers that people die from are things like lymphomas and lung cancers. But you can see in the small print at the bottom there that these two studies are really very, very different. The time period is very different. The study that looked at cancer incidence was from 1980 to 2007, whereas my study, which was looking at cancer-related death, was for a slightly later time period. The Dave Collette paper was looking at all solid organ transplant patients, whereas my study was only looking at kidney data. They were both looking at very different data sets as well, and they were also looking at very different patient groups. The cancer incidence paper was looking at a England, Wales, and Scotland cohort, whereas the one that I was involved with was only looking at an English cohort. So it this is the nature of a lot of these studies, that when you're trying to compare things, obviously you can't compare these two studies because they're looking at different things. One's looking at how much cancer you get, and the other one's looking at how many people die from cancer. But when you're comparing these studies, especially between different countries, you always need to be very careful that you're not comparing apples to oranges, for example. So there are lots of limitations to these studies, and some of the classic papers that we use to kind of quote to patients as to what their risks are very, very dated, and some of them are probably about 20 years old now. I've already mentioned that when it comes to transplant research, and especially when it comes to using data, the United States often is very heavily represented in the research articles that we often read in our journals. But the United States is a completely different beast to the UK. The patients are different. The transplant care they get is different. Even the type of immune suppression that they get is very, very different. And we've shown when you compare transplant patients in England versus New York State that the patient cohort is very different, and the outcomes we see are very, very different. So you can't just translate data from the US across the pond. And also, when you look at the data, it often gives you very different readings. So SMRs means standardized mortality ratio. What that does is it gives you a figure compared to the general population. So if you have a standardized mortality ratio of 2 for a transplant patient, it means that if you look at a very similar age and sex matched person, they, as a transplant patient, will have double the risk for getting a cancer versus the general population. And if you look at all the different studies, and these studies are all from very different countries, either from England, Canada, Australia, or the US, they often report very different figures, and that will reflect the fact that they will be looking at things ever so slightly differently, perhaps looking at different time periods, and essentially they're looking at very different patients, even though everybody has a transplant. And also it depends on what kind of data you're looking at. We've got transplant registry data, but then you can also have hospital admin data as well. And there are advantages and disadvantages to all these different data sets. So we need to be very careful that we're trying to get a complete picture when it comes to cancer after transplantation. And this is important because depending on which study you look at, we can interpret different things, which means that when we're counseling patients, or when we're talking about patient care in our kind of multidisciplinary meetings, depending on what study we're quoting, we will give a very different picture to people. So for example, I've already shown you that many studies suggest that the risk of dying from either getting breast or prostate cancer, or dying from breast and prostate cancer, is actually lower for transplant patients compared to the general population. But the United States has shown that actually, no, these two cancers are associated with a much higher risk. So different studies showing different things. Again, some studies have suggested that older transplant patients have a much higher risk for cancer-related death, and that would fit in, for example, with what we see in the general population. But other studies from different countries have shown that older people do not have a higher risk for death, and that dying from cancer as a transplant patient is more skewed for younger people, and perhaps older people have what we call competing risks for death. They may have a higher chance of dying from things like heart attacks and strokes, etc., etc. And again, some studies would suggest that having a cancer before you get your transplant increases your risk after transplantation, either of that same cancer coming back, of getting it, or of getting a brand new cancer. But again, that's not a consistent finding, and some studies have suggested that the risk for cancer after transplantation is not increased if you've had a previous transplant cancer, and that may be because they've been more aggressively screened, or there's maybe a bit more surveillance of them. So you can see that the literature is a bit of a hodgepodge, and depending on what study you're looking at. And the problem then is that we don't really have any guidelines on what we should do after transplantation, either because of screening or prevention, or how we manage things. So for example, I mentioned earlier that there's a certain virus which is commonly associated with lymphomas, and that's the Epstein-Barr virus. And in the UK, the guidelines are that we should not be using this screening test, which is just a blood test that we can do to screen for lymphoma. It is recommended for people who get stem cell transplantation, and it is recommended for children who get a transplant. But for adults, the advice is that we shouldn't be using this blood test for this virus as a screening tool. But that's different advice in the United States. There, they recommend that certain patients should be getting screening with this. Why is there a different practice? Well, because there's very little data to support one versus the other, and I don't think there's any right or wrong in either of those approaches. And because of all of this, management of patients can be very difficult. We may not be able to use some of the therapies that we can use in the general population. Our transplant patients have so many competing risk factors. There's so many things. Cancer is just one thing which our transplant patients may be exposed to. There's so many other things: infection, risk for rejection, etc., etc. And as I mentioned, what we all do with immune suppression can be very, very different. That therefore leads me to this particular study. So it's called EPCOR, which is Epidemiology of Cancer After Solid Organ Transplantation. And essentially, what I was hoping to do was to try and link various data sets in the UK so we could get a complete picture for transplant patients for their journey from transplantation to either them getting or not getting cancer and other outcomes. So I actually had the idea for this project in 2014, but it's been a very painful journey. I'm not going to delve into all the multiple hurdles I had to jump through, but certainly I felt like an Olympian running the hurdles match in the Olympics for the amount of things I had to do. And over this time, the group that had to get data from has changed its name so many times, and even now NHS England will probably be changing to somebody else, and just shows you how long it's taken to get this data. And there's certain reasons for it. I think for many of the patients on this call, use of your data is a very sensitive thing, and therefore there's lots of legal approvals that we have to go through, which I'll show you on the next slide. But I always show people, this difficult journey that I've had over the last decade, and it's always interesting to show you all the different things that have happened over this last decade and all the various kind of life events. And even for me personally, I've gone from having 2 young boys in 2014 to having 3 boys now, one of whom is a teenager and is only now half an inch shorter than me. So it's been a long journey. And this is the reason why we have to be very careful with patient data, because it's impossible for me to go out to all the tens of thousands of patients to get permission from each and every single one for me to use their data. And of course, because the data set which I was interested to look at goes all the way back to 1985, and some people may have passed away 10 years ago, so I can't get consent from someone who is no longer alive. So there is a mechanism in the UK where we can access this data, but we have to get essentially legal approval for use of data without seeking direct consent from patients. You have to be able to justify what you're doing, and therefore you have to show that there is some clinical benefit and it's in patients' interest to get this data. And that's all the legal jargon on the left there. And that was quite a long journey to get all this data, but I'll just talk you through what all these different things are. So obviously the transplant data that we have to record. So every person who has a heart, lung, liver, kidney, pancreas, whatever, we will record information about the donor who donated that organ. We will record certain information about the people who receive that organ as well. And some of that is mandatory. We have to record that data, and we have to report that data to NHS Blood and Transplant every year, and that forms part of the registry report, which is openly available to everyone. We can also get data for anyone who's died in the UK. As many of you may be aware, if you've had loved ones who've passed away, there will be a death certificate. That death is then registered and has implications for kind of cessation of pensions and benefits, etc., etc. And we can access the records for that to find out who has died and what they've actually died from. 10 years ago, when I was doing this, cancer data in England was held by Public Health England, and then they would have lots of information about what kind of cancer people had, what kind of treatment they had, and things about their radiotherapy data. So I was very keen to have that. And then this thing here, which people may not be familiar with, this is hospital episode statistics. All hospitals, if there is any patient interaction, whether patients get admitted, patients have any kind of procedure, whether it's a transplant, whether it's an angiogram, or whether you've had your gallbladder removed, we will record all that information, and that is what becomes this hospital episode statistics. And there's lots of information about all the patient care that you will have, either as an inpatient when you're admitted to hospital or even as outpatient. So a whole wealth of information. And essentially what this process was that, I'll just go back, would be that NHS England would take all this data, they would link all this data, they would then remove any identifiable information. So we would never have anything about, there's never any names, no date of births, no NHS numbers, etc., etc. And what we essentially get to study is a completely anonymized data set with nothing identifiable for any patient. All we have is patient 1, patient 2, patient 3, all the way up to 85,410 patients. So it's a completely anonymous data set that we have. And there's a certain process for how that gets linked, but that is done by NHS England without any researchers being able to see any of that identifiable information. So I'm just going to quickly show you two presentations which were presented recently at the Congress in London, and it's really just to kind of give you a flavor for some of the early data we're getting, and hopefully shows you some of the potential for this data. So the first thing we wanted to do was to look at how much cancer do we see after solid organ transplantation in England. And again, I've kind of explained to you already that there's lots of studies out there. These are from the US, from Finland, Japan, Sweden, but they all report very different things with regards to how much risk that there is. So because this data can be so variable, it's very hard for us to counsel patients when they come in as to what their risk for cancer is. So I've already explained to you how the EPCOR study worked. For this particular study, what we did is we excluded people who had what's called a non-melanoma skin cancer. So that's your basal cell squamous cell carcinomas. And for this particular study, we've also excluded anyone who had a previous history of cancer. We do have that data, and we will be looking at that data to answer some of the questions which I've touched upon. So this is this particular cohort. As you can imagine, most of the transplant patients in England are from are kidney transplant patients, and then liver comes second, and then everybody else, heart, lung, pancreas afterwards. So there's about just under 63,000 patients who had just over 70,000 transplants, and we had a kind of a median follow-up of just under 9 years. So just to give you a little bit of a flavor, the commonest cancers that we were seeing, so remember we've excluded kind of non-melanoma skin cancers. Lymphoma is the commonest cancer that we see, followed by lung, bowel, kidney, and then liver. And in this particular chart, what we're doing is we are comparing the risk for cancer for the transplant patients versus the risk out there in the general population. And Cancer Research UK, for example, holds a lot of that data. So you can see that actually the overall risk is a lot lower than what is reported in a lot of the studies. So essentially what we can say here is that as a transplant patient, you have a 29% higher risk for getting cancer as a transplant patient compared to if you were out there in the general population without a transplant. And that's certainly lower. It's significantly higher, but it is lower than what we see in the general population. And you can see it doesn't matter what kind of transplant you've had, everybody has a higher risk. We also find that the risk is high for both men and women. In the general population, men tend to have a bit more cancer, and what we found here is that men who have a transplant have a higher risk for cancer than the general population men, and women have just ever so slightly higher risk than women in the general population. But what's interesting is if you look at the risk for cancer versus the general population, you can see that the highest risk is actually for liver cancer. I'm not going to delve into this too much, but this particular risk is predominantly for people who have a liver transplant. And remember, we've excluded people who had hepatocellular carcinoma, so liver cancer, as a cause for them needing a liver transplant. So again, may fit into with the story that people with liver disease may have some kind of inflammation which primes them as being a slightly higher risk for cancer. Lymphoma is the second commonest cancer that we see, and you can see that kidney cancer is the third commonest. And again, that's very much skewed for kidney transplant recipients. And there's already pretty good literature that the longer people spend on dialysis, the higher their risk of getting kidney cancer in their old kidneys after they receive a kidney transplant. And I'll just finish off with the kind of the sister paper that was published, that was presented at the ESOT Congress, and this is looking at cancer mortality. So again, whether you look at Canada, Australia, New Zealand, Ireland, or the United States, they all report very different data. And you can see that the time periods are also very variable as well. So we wanted to get some accurate English data. So very similar study design, same kind of slightly longer time span because we've had mortality data going further back. And I'll just kind of talk you through a lot of this kind of data that we have here. So you can see that there's just over 50,000 patients for this analysis. Just as we see for our transplant cohort, just under 2/3 are men, and about 76% of the patients in this data set are of white ethnicity. And again, about 2/3 of patients are kidney transplant patients, but we've got a sizable number of other transplant patients as well. So a slightly longer follow-up because we were able to go back a little bit further. So you can see that we followed up on average people for just under 12 years. About a reasonable number of patients died over this long period of time, of whom about just over 15% died from cancer. So cancer was actually the second commonest cause of death in this EPCOT data set. And what are the top 10 cancers? So you can see the lung is actually number 1, with non-Hodgkin's lymphoma as number 2, and then cancer of unknown primary was number 3. And again, a very similar chart. So again, this is comparing the risk of dying from cancer for a transplant patient versus the risk of dying from cancer in the general population. And you can see that the risk here is higher. So there's just over double the risk of dying from cancer as a transplant patient compared to someone similar age, similar in the general population. And that risk is consistent across all the different solid organ groups. Very small numbers for people who get heart and lung transplantation, and that isn't statistically significant, but perhaps with more patients it probably would be. And again, we found that patients who were white had a much higher risk of dying from cancer than people who were black or Asian, and that's a phenomenon that's also seen in the general population, and that liver, lung, and heart transplant patients have a higher risk of cancer death than kidney transplant patients. And that's interesting because we blame immune suppression so much, and heart and lung patients may get more immune suppression than kidney patients, but certainly liver transplant patients tend to get less immune suppression than kidney patients. So there may be other reasons why there may be a higher risk for cancer for liver patients. And we will be delving into the liver data more specifically, as we will for all the other transplant groups as well. And again, just looking at the distribution, you can see that there are certain cancers which are overly represented, and again, it's liver cancers, the lymphomas, cancer of unknown primary origin, and then kidney, and then everything else follows through. Again, you can see that the risk of dying from breast and prostate cancer, breast cancer, there's not much different risk from the general population. Probably a low risk of dying from prostate cancer for a transplant patient versus the general population. So a low risk of getting prostate cancer and a low risk of actually dying from prostate cancer. So just to conclude, what this kind of early data shows us is that the risk of getting cancer after transplantation is higher than the general population, but probably a little bit less than what is reported. There's a few reasons for that, maybe because our data is a bit more contemporary. We have excluded people with previous cancers. Other studies have sometimes included that, but we will be looking at that group because they're an interesting group, and it'll be interesting to find out what the cancer risk is there. But very similar to what is published, we found that the risk of dying from cancer is twice as high for transplant patients compared to the general population. I've also shown you that the risk varies by different organs, and it also varies by cancer site. But hopefully what I've shown you is the potential for patient benefit with this data set, and there are very big benefits of data research. So what kind of answers can we answer? We should be able to answer these kind of questions, and we'll be delving into these further. We haven't got very granular data, so we haven't got blood tests or virus tests, so we won't be able to answer this particular question. But we will be able to maybe answer some of these questions. For example, we will have some data on chemotherapy, and we will have data on competing risk factors as well. But the plan for this project is that we wish to kind of expand this data set, when it comes to renewing its approval. We are changing the kind of the handling of the data so that the university controls everything. But when we get an updated data set, so rather than stopping at 2016, if we get data up to 2025, then we should have over 100,000 transplant patients. And NHS England holds lots of data sets. So in theory, we should be able to get data on what medications people are taking, and that would really help answer the question about what transplant doctors are doing with immunosuppression. Of course, NHS England also holds data sets on maternity services, mental health services. So we'll be, if we can link those data sets as well, we'll get a bit more information about the risk of, say, transplant patients when they have pregnancies and what the risk of complications or mental health issues. And again, there are other data sets. There's diabetes data sets. There's this cardiovascular data set, which if we can link to this existing data set, we will have a very rich tool that we can use to answer questions beyond just cancer care. So what's the risk of having hip fractures after transplantation? What's the success rate for people? What's the survival rate after various operations? We haven't really got that kind of data for transplant patients, but we could do if we analyzed the EPCOT data sets. And it really just shows the benefit of patient data which already exists, which already is out there, but we can make good use of it so that we can answer some of these questions that we don't have answers to.